Hey everyone, this lecture is for Chapter 20, Inpatient and Outpatient Addiction Treatment. So what does it look like? This chapter goes into talking about what it looks like for individuals with addictive use disorders to enter these types of treatment facilities. And we're going to talk more about ASAM criteria of care, which we've talked about in two other occasions. We're going to talk about it in more in depth. And so as you hear this lecture and read the chapter and really explore ASAM criteria, think back to that case study that you all did and just kind of for our treatment plan activity, I want you to kind of like start putting all of this together. So inpatient, outpatient addiction treatment centers, commonly referred to as rehab. So let's get into talking about what rehabs are like and sort of what goes into placing or referring clients at addiction treatment centers, whether it's inpatient or outpatient. I want to start off the bat by just sort of talking about some SAMHSA relapse rates. And this is important because what you'll find is individuals enter into treatment centers, for lack of a better word, often. Relapse and addiction is oftentimes sort of the relapse with addiction is oftentimes expected, and whether you like it or not, oftentimes it is presented in that way for clients. You will more than likely relapse, and this is why we're going to talk about prevention, and this is why we're going to talk about sort of addressing problematic behaviors. But as you can see here, these relapse rates, according to SAMHSA, are pretty high. So, I always ask this question when we talk about this chapter to my students. I always ask, would you go to a physician, or would you have your car looked at, or would you have work done on your home if this type of percentage was what you were presented with? If you went to a physician and they said you have cancer and there's an 86% chance that it will resurface, we wouldn't think that that's pretty high rates, that's not great. And unfortunately, this is what we know about addictive use disorders. So I just wanted to put that out there first, and then we're going to sort of jump into the services that are delivered in inpatient, outpatient treatment and what that's like. I also provided you all with a John Oliver video. Now, John Oliver sort of makes light of some interesting information that's accurate about rehab and treatment facilities, inpatient, outpatient treatment facilities, and I'm really curious about your perspective and what you feel about inpatient, outpatient treatment centers, especially after watching this video. Again, he makes light of it. He's a comedian, but the information presented is unfortunately quite accurate. Okay, so when we talk about matching your client to the appropriate level of treatment, we always talk about considering continuity of care or continuum of care. And what that means is you want to match the level of appropriateness, your client's level of appropriateness, and the treatment setting. So it's a treatment system in which clients enter treatment at a level appropriate to their need. I'm looking at my notes here, sorry. And then step down or up to a more intense level depending upon what they need. So essentially what this means, and I mentioned some of this to you in that case study, you never want to start your client off at the highest level of care if they have not been unsuccessful at a lower level of care. So this is a dramatic example, but if you stub your toe, I'm not going to automatically chop it off. Does that make sense? If you, so how that relates to addiction treatment is if an individual is considering that they have a problem with, let's just say, alcoholism. It's starting to cause me some problems. My family members are sort of noticing some behavioral changes that they don't particularly like. They're asking me to get help. You wouldn't necessarily send that client to a super intense inpatient treatment center where they will be removed from their home, removed from their job, removed from all their responsibilities because they have not had the opportunity to be unsuccessful at a lower level of care. You would start them off at a low level to see if that sort of approach or that intervention would benefit them. If it does, great. If it does not, then you increase the level of care, and that goes on and on and on and on and on. You look at 3 different dimensions: admission, continued stay, and discharge. So what's going to happen for this client with these specific set of behaviors, set of consequences, set of physical issues and concerns? Is there withdrawal? Do we need detox? Whatnot? We look at that upon admission. And then what is it going to be like for them to stay in this treatment center? Again, is it a lower level of care where they only have to come see you for 50 minutes a week at a private practice setting, or do they need to be removed from sort of their substances and the world for a bit and have more intense treatment at an inpatient facility? And then what is it going to be like for them at discharge? If they are at a high level of care with a lot of structure, then how are you discharging them so that way they can continue to have that support in less and less increments? So we'll talk about that as we go on. This is ASAM criteria. You guys have all of this, and so you know these dimensions. These are the levels of care. So specifically early intervention. So what does early intervention look like? Excuse me. Early intervention, we're looking at, and this is directly, I'm taking all of this directly from, where do I have that? Oops, sorry, I'm going the wrong way. Here we are. Early interventions. I'm taking this directly from your PowerPoints. Early intervention. Intervention services that are provided for clients at risk or those who might have a substance-related problem. They may not meet the criteria for substance use disorder, or they meet it sort of in that moderate or that mild, maybe moderate range. But this is, we're going to try to change these behaviors and change and address these negative consequences in a less intrusive, less supervised, less involved way. Outpatient treatment. So moving on to outpatient treatment, this is non-residential. They do not live there. Clients do not live in this environment. It's scheduled sessions, both group and individual sessions. And as you can see by the PowerPoint, the goal is to lessen the severity of use, lessen the severity of consequences, and achieving that desired goal, which could be abstinence, but it could also be moderation, warm turkey approach, lessening the amount of substances used. A great example of that is with alcoholism, alcohol and alcoholism. So I don't necessarily want to completely abstain, but I would like to change the amount I am drinking. Intensive outpatient treatment, which is also referred to as IOP, as you can see, intensive outpatient, IOP, or partial hospitalization. So this is an outpatient setting as well. However, it's much more involved. Folks in an IOP usually come 4 or 5 days a week to the treatment center, and there's group and individual settings before and or after work or school. And they may have to come on the weekends, and then of course some on the weekdays. There's a case management component too, so maybe plugging in to, if you're a counselor working in an IOP, you will be expected to do some of this case management, maybe referring to psychiatrists, referring to housing if that's necessary, but navigating more severe addictive use disorder, but allowing for the client to continue to go to school, work, and fulfill family and role obligations. But again, the treatment is more intense. The treatment, there's more oversight. With outpatient and IOP, there's usually some drug screening involved. More oftentimes than not, there's drug screening involved. Of course, the more intense the level of care, the more intense that type of oversight gets and becomes. Residential or inpatient. clients live in this type of facility. They live there. They are removed from their home. They are removed. Oftentimes, folks are homeless at this point. I worked in a homeless treatment center where this was a free facility. We received funding from grants and fundraisers and et cetera, but this was a homeless addiction treatment center. And so they had lost their job, they have lost their home, all due to their use or co-occurring mental health issues. Some comorbid mental health issues may also be present, of course, and that needs to be assessed and addressed at all levels of care as well. But this is super structured, very defined. They have schedules. Folks in inpatient know, when they're being monitored all the time. They have group, they have individual, they may have art therapy, they may have exercise, but it's very intense and very involved. And you can see the main goal is that safe, stable, not stable, that's a typo, safe, stable living environment to create that recovery experience and to support it. And then medically managed inpatient care. This is more of what maybe you would think like a psych ward or a much more hospital type setting. They're medically managed, they're on medication. These are oftentimes folks with severe mental health issues and addictive use disorders. So maybe, severe cases of bipolar, maybe bipolar with psychotic features or schizophrenia, depending upon, how they enter treatment. And of course, those past experiences with recovery and treatment, individuals may end up in one of this type of managed care or managed inpatient treatment. I want to reiterate this again. It is never appropriate to refer or suggest that an individual go to treatment at a level of care that is not appropriate and does not match their prior experiences, the needs that need to be met, and the level or severity of their addictive use disorder. Have they been unsuccessful at a lower level of care? If the answer is no, you start there. And of course you need to, this is an individualized approach. You need to consider every case. If an individual is homeless and needs treatment, then you may jump to an inpatient facility that will give them a stable place. So that's super important. That's real important, and you have to look at these on a case-by-case basis. I'm not going to go over readiness for change, but that is a factor you need to consider when looking at inpatient and outpatient treatment centers. Some challenges, let's talk about this. They're real expensive. Treatment centers can be real expensive, and those treatment centers that are not expensive oftentimes struggle to deliver quality care. So funding is obviously a problem. There's the stigma around entering into rehab. Not everybody can just sort of escape from society and escape from obligations and enter into treatment secretly. And then, of course, staffing. The treatment centers don't necessarily pay a ton because of this funding problem. And so it's hard to sort of keep quality staff. I've worked in a couple of these environments, and as unique and as fruitful and beneficial as these treatment centers can be, they do certainly present some problems. Here's just some experiences. I want you to sort of read through this in the text and then also watch that video. I also want you sort of to maybe recall some of what you know about rehab or treatment facilities, and just kind of put all this together for your, for you to sort of look at treatment through this lens of what is clinically appropriate and also what do you know that needs to be challenged. There's some bit of information about rehabilitation versus incarceration. We just, short answer, we don't do a very good job of separating addictive use disorders and prison population and incarceration. And so substance use treatment delivered to incarcerated or offender populations is usually not that effective. I'm going to stop here. Make sure you look into drug court.